Thanks for listening to the GOSH podcast, the Gynecologic Oncology Sharing Hub. We share real, evidence-based discussions on gynecologic cancers featuring stories from patients, survivors, researchers, and clinicians. Our podcast is produced and recorded on traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. It is produced by the Gynecologic Cancer Initiative, a BC-wide effort to advance research and care for gynecologic cancers.
All right, well, welcome everyone to the latest episode of the GOSH podcast. My name is Carly and I will be your host today, interviewing Dr. Madeline Rhind. Welcome.
Thank you for having me.
It's great to hear such a beautiful tone in your voice for our people who are in Canada listening, because you are from New Zealand.
Yes, that's correct.
What part of New Zealand are you from?
So I grew up in Palmerston North, which is a town kind of a couple of hours from Wellington.
Okay, perfect. I've been to New Zealand, but not on that side.
Yeah.
Fantastic.
I did most of my training in Auckland, so I was living there for the last 10 years or so.
Right. And so that's where you did your medical oncology, is going on now at BC Cancer, and you completed the rest of your medical training in New Zealand and Australia, correct? Yeah.
Yes.
And so how did that bring you out to Vancouver, Canada, when you were doing most of your training out that way?
So I came here for a fellowship opportunity, essentially. So BC Cancer has a, excellent international reputation. And I also really liked the idea of a little adventure to Vancouver.
Why not?
So that's kind of how I ended up here.
Oh, perfect. We love that. So we're going to talk a little bit more on the depth of the work and the identification of druggable targets and prognostic biomarkers in vulvar do I say it right? Squamous cell carcinoma.
Yeah.
Well done. It's a mouthful. And I mean, I don't know if you know, but I'm a 2-time vulvar cancer survivor myself, and I still can't pronounce that properly. So, it's not an easy one.
Yeah.
So why don't you start it off and kind of explain what vulvar squamous cell carcinoma is and why it's an important area of research that people may not hear about very often.
Of course. So vulvar squamous cell carcinoma is essentially just the most common form of vulvar cancer. And squamous cells, they're like the lining cells of the body. So we have them on the surface of our skin, but we've also got them in, say, like the lining of the lungs or the esophagus or the bladder. So the squamous cell is just the cell that this particular type of cancer starts from. And the cancer can really form from 2 different pathways. So one of those can be associated with the human papillomavirus or HPV virus. So that is also the virus people might have heard of as associated with cervical cancer. And, the hope is that as we start to see the effects of HPV vaccination, all of these kind of HPV-associated cancers will become less prevalent. So that type of vulvar squamous cell carcinoma that's associated with HPV tends to affect younger women. And it's actually associated with a better prognosis. And then we have the other form of vulvar squamous cell carcinoma that isn't associated with HPV. And that type is more commonly associated with underlying inflammatory skin conditions like lichen sclerosis. So that's something that tends to affect older women. So they both start from the squamous cells, but they're just driven by different pathways. And you mentioned that your listeners might not have heard of this cancer before, and that's because, fortunately, it's a rare cancer. And what's even rarer is for this cancer to be diagnosed at a point where it has spread and metastasized to other places in the body. And that kind of makes sense because the vulva is like the external genital area. And so if you have a cancer there, you're likely to notice some changes. You might kind of feel a lump or a bump. So fortunately, it gets usually detected early, and then we can give treatments like surgery and radiation to cure women of this cancer. Yeah. What that means, though, is for those like unfortunate women whose cancer has spread to other places in the body, is that it's so rare that it doesn't get a lot of attention, it doesn't get a lot of research funding, and then we don't have evidence to even guide our treatment. So instead, we borrow treatment protocols from cervical cancer, and that results in our patients having worse long-term outcomes. And actually, metastatic disease in this setting is associated with with very poor outcomes. So
Right.
that's why I think it's an important area of research. Yeah.
Absolutely. And I obviously know more about it now as a cancer survivor, a vulvar cancer survivor. I didn't really even, to be honest, know too much about my vulva before
Yeah.
I
Yeah.
got this cancer, but I am finding more people with this cancer than I ever have, and since I was diagnosed in 2014, and mine was not HPV related, like you talked about different pathways, but it is out there more, and pain is our friend. Like you mentioned, you feel that bump, and that's what alerted me to mine and ultimately saved my life, because the cancers that don't give those types of warnings sometimes are diagnosed too late.
Yeah, absolutely right. Yeah.
Yeah. So when you talk about druggable targets, what are you looking for at the molecular level, and how could that translate into new treatments?
Sure. Um, so I guess when I'm talking about druggable targets, it's helpful to kind of think about what we do in medical oncology and what treatments that we give. So if you came to see a medical oncologist, 15 years ago, the only tool I've got in my toolbox is probably chemotherapy. And chemotherapy is great, and there's a real time and a place for it, but it's a very blunt tool. So all it does is it targets cells that are turning over and dividing rapidly. So we can kill those bad cancer cells, but we're also going to kill the good cells. So things like the cells that are made in your bone marrow that are turning over and dividing rapidly. They're going to produce these like infection fighting cells, and that's why you're going to be immunosuppressed when you have chemotherapy. So there's a lot of toxicity and side effects. So we're trying more and more to make our treatments more targeted and more personalized. So for this study, what we were specifically looking at is we were looking at targets for a new type of therapy that we're increasingly using in medical oncology. And that therapy, the drugs are called antibody drug conjugates, or ADCs for short. It's still chemo, but it's chemo that's attached to a special antibody. And that antibody acts a bit like a key to a cancer cell. So the cancer cell has to have the lock on the outside, and that's a receptor or a protein. And so when the antibody drug conjugate enters the bloodstream, it circulates all through the body, and it acts a bit like a missile, and it only attaches to the cells that express that receptor. And then the whole complex, the chemotherapy and the lock and key, can get internalized into the cancer cell and deliver the chemotherapy specifically to those cells. So it's a really targeted delivery of chemotherapy. So you can
Wow.
imagine like the perfect ADC would be targeting a receptor that's just expressed on cancer cells and not
Yeah.
anywhere else in the body, and ideally on all of the cancer cells.
Right.
So, yeah, so I hope that makes sense. But
It does. It does. Yeah.
so what we looked at for this study is we actually looked at 6 receptors that already have antibody drug conjugates approved for use in other cancers. So there's already drugs available. And we just wanted to see, does vulvar cancer express those receptors?
Hmm.
So that's kind of the druggable targets that we were looking for with the study.
Right. That is so interesting. Where was this study in 2014 when my cancer was diagnosed? Because that's not what I went through. What types of biomarkers are most useful in vulvar cancer right now, like prognostic, predictive, or both? And what role do they play in patient care?
Sure. So I think maybe it would be useful just to kind of step back and say what a biomarker actually is.
Sure, yeah.
So a biomarker is just something that we can measure. So you could have a biomarker that's measured from a blood test, or you could have a biomarker that's measured from looking at your tumor biopsy. And then when we have a biomarker, we can say it's a prognostic biomarker or a predictive biomarker. Prognostic biomarker is really just telling us how aggressive the cancer is. So it's not telling us anything about the treatment. It's just saying, look, women who have this biomarker, their cancer tends to act in a more aggressive way, and this is more indolent. And then the other type is a predictive biomarker, and that's telling us something about response to treatment. So it's saying patients who have this biomarker are more likely to respond to this specific treatment. So at the moment in vulvar cancer, we definitely do have some prognostic biomarkers. We talked a little bit about the importance of HPV status. We can actually measure HPV status quite easily looking at the tumor tissue to see if it expresses a protein called P16. So that can be used as a surrogate for HPV infection. And then we can say, look, women who have a P16 expressing tumor have a improved prognosis. We can also look at the flip side of that and say within the group that don't express P16, do they have abnormal P53 expression? And unfortunately, abnormal P53 expression, which is most of the non-HPV associated tumors, tend to act a little bit more aggressively. So that's prognostic. There's a slight predictive element as well, in that the HPV associated tumors can often be more responsive to radiation treatment. But I would say that's not as well validated as some other predictive biomarkers. We do not have any predictive biomarkers currently that would guide our systemic treatment. So there's nothing that I could test that would say this shows me that this drug is going to work really well for you or not work really well for you.
Mm-hmm. Wow, there's so much like deep digging, diving to figure out, because each patient will also be so different. So you need to vary the treatments for those patients, right?
Absolutely.
So those
Absolutely.
biomarkers are essentially guiding the care that that patient's going to receive.
And sometimes we have to make sure that they're really well validated before they get to that point, for sure.
Gotcha. Gotcha. Wow. And so with vulvar cancer being, very quite relatively rare, how does that rarity come to affect the research progress, the clinical trials, and ultimately patient outcomes?
So I think the rarity has a huge impact. If you look even at just gynecological cancers in general and the amount of funding that they get and compare that to some other forms of
Mm-hmm.
cancer like prostate cancer, gynecological cancer is getting less funding. And then, vulvar cancer on top of that is a rare cancer, and that means it doesn't have the public attention. People don't know about it. There's no campaigns for it. So it's getting less money. And then less money leads to less clinical trials. On top of that, even if you had the money for a clinical trial, how are you going to recruit patients for a large randomized phase 3 clinical trial with such a rare cancer? It's going
Right.
to be impossible.
Yeah.
So we don't have these big trials, and I can't say, I'm going to give 500 women this treatment and 500 women placebo, and then do some really robust statistics to show the survival advantage. So we're never going to get that level of evidence. And then you can take that a step further than say, if a government is looking at how they're going to allocate money to drugs, it's much easier to justify allocating money to a drug that's got this huge phase 3 trial.
Mm-hmm.
So it has a big knock-on effect, and I think we can see that directly in our outcomes for our patients, particularly with those, patients with metastatic disease.
Absolutely. Because you need to have the amount of patients to do the proper trial to get the proper results. And with
Totally.
a rarely diagnosed cancer, you're not going to have all these women to pick from because they're just not there like other cancers that are more prevalent would be, right?
Yeah. Yeah, that's
Wow.
absolutely right.
Yeah, that's crazy. So what do you think are the biggest challenges in making those discoveries a little, more talked about, known about, or like the biomarkers and the drug targets from the lab into the real world clinical care?
Yeah, so the pathway from, finding something in the lab to then making it applicable for clinical practice is long, and
Mm-hmm.
there's a good reason for that, and we need to make sure that it's really well validated. So you could take the study that we have done just as an example and say, look, you've found that there's 3 of these 6 receptors are highly expressed in vulvar cancer. You've tested the primary tissue and you've tested the lymph nodes, but I haven't tested distant metastatic sites like the lung, the liver, to
Mm-hmm.
see, is there a difference in the expression of the receptor in those sites? Because I don't have that tissue, because people haven't gone and done these unnecessary biopsies.
Yeah.
So, I could find when I tried to do a clinical trial that actually the receptor is not expressed as highly in those distant sites, and therefore the drug wouldn't work as well there. Other issues might be just because the receptor is expressed doesn't actually mean that the drug's going to work. So
Right.
I could have a drug that works really well in, like, say, bladder cancer, enfortumab vedotin for Nectin-4, that's one of the receptors. it might not work in vulvar cancer. It might not, even if the receptor was highly expressed, maybe when the lock and key bind together, maybe there's an issue internalizing it into the cell that we didn't anticipate. So
Mhm.
those are the kind of things that you could find when you go and you design your clinical trial and you're really optimistic and hopeful that these drugs are going to help patients. Maybe they won't. So these are all kind of hypothesis generating studies, and they're the first step of many steps until making something that actually changes day-to-day
Right.
clinical care.
Yeah. And just like a little side note to that is like, I remember during treatment, they asked me if they could keep my tissue and they could use it for research and like all these things. And at the time, I was like, yeah, sure. I'm just trying to stay alive. I didn't really understand the why. But
Yeah,
as I've gotten more involved with this podcast and other advocacy type platforms, I understand now that that's what we need to help the next person to get these trials to, biopsy. I'm not a doctor, but to whatever research that tissue helps is what we need to find out more solutions for the next one coming down the road.
absolutely. It's where a lot of our first kind of steps come from in the science. So it makes a huge difference, and having patients like you volunteer to be part in this is massive. I may have
Right.
actually included a bit of your tumor in this,
You
in
got to
this
look me
study.
up in the files. My file is really big at PC Cancer. Like you cannot miss it. It is very big. I am very visible there for sure. Oh my word, that's too funny. So if we were to kind of like close out this chat right now, if we were to think about like one thing that you really wanted to point on for research priority that could most improve outcomes for patients like myself and other people currently going through vulvar, I can never say it, squamous cell carcinoma, what would it be and what would your reasonings be for that?
So I think specifically for vulvar squamous cell carcinoma, the bit where I see the biggest gap in terms of outcomes would be our patients with metastatic disease.
Right.
And I think what we really need with these rare cancers is more kind of innovative approaches to trials.
Mm-hmm.
So we need huge amounts of international collaboration, which we're really good at. And then, it's things like if we can't do a randomized phase 3 trial, could we do like a basket trial where we take everyone who's got this biomarker, regardless of where their cancer started from. So a gastric
Mm-hmm.
cancer, a rare vulvar cancer, and actually just in a kind of like we call it tumor agnostic way,
Mm-hmm.
just see does this drug work for cancers that express this biomarker. Or
Right.
if we just want to focus on vulvar cancer, we could do like an umbrella trial and say, I'm only going to recruit women with vulvar cancer, but I know only 40% express this receptor, 30% express this receptor, and I'm going to test multiple different drugs within the same trial.
Mm-hmm.
Logistically really challenging and comes with its own issues, but I think until we can kind of include these patients in trials, we're just not going to have the evidence to guide our care.
Absolutely. We don't want to see this cancer grow and get more aggressive, but as it does, the research will only get better because we're going to have more people that have gone through it and we can do this type of research with, right?
Double-edged sword, yes.
Yeah. Yeah,
Yeah.
I know, very double-edged for sure. Yeah. Well, thank you so much for taking your time. I hope that you're enjoying Vancouver. I mean, I've never been to your part of New Zealand, but when I was in New Zealand almost a year ago, I found it very similar landscape wise to BC, right? To the Vancouver vibe. Same thing with Australia. So I hope we give you a little bit of sense of home here because you're coming here to help BC Cancer and also helping you is only going to help the next cancer patient. So from a survivor, I'd like to thank you. And too bad I didn't get to meet you at my last checkup, because you're not in the rooms like you mentioned to me before this. You're doing more in the treatment type sides of things with patients, right?
Yeah, well, it was lovely to meet you, and thank you. I have felt very welcome here in
Oh,
Vancouver.
yes. Well, thank you so much for your time and everything you do for the patients out there.
You're so welcome. Thank you.
Thanks for joining us on the GOSH podcast. To learn more about the Gynecologic Cancer Initiative and our podcast, make sure to check out our website at gynecancerinitiative.ca.